The topic of our lecture: diffuse connective tissue diseases. In this lecture, we will discuss juvenile rheumatoid arthritis, systemic lupus erythematosus, systemic scleroderma, dermatomyositis, polyarteritis nodosa, and acute rheumatic fever. Juvenile rheumatoid arthritis. It is a clinical syndrome in which one or more joints show inflammatory changes. American Rheumatism Association defined it as arthritis of one or more joints with onset before age of 16 years and persisting for at least 6 weeks, with the exclusion of other specific diseases such as ankylosing spondylitis, psoriatic arthritis, arthritis of inflammatory bowel disease, infectious and polyinfectious arthritis and other rheumatic disease. European leader against rheumatism used the term juvenile chronic arthritis instead of juvenile rheumatoid arthritis. For arthritis persisting for 3 months, but including ankylosing spondylitis, psoriatic arthritis, and arthritis of inflammatory bowel disease. Etiopathogenesis of juvenile rheumatoid arthritis is not known. A broad range of autoantibodies has been reported. Stimulates production of immunoglobulin G and immunoglobulin M, anti-immunoglobulin G rheumatoid factor. The antigen-antibody complexes activate the complement system, causing productions of substances which attract neutrophils in joint spaces. The latter phagocytose the immune complexes and form rheumatoid arthritis cells. This release hydrolyse and other enzymes from the lysosomal granules and initiate destructive changes in joints. Polyunsaturated fatty acid metabolites and prostaglandin along with fibrinogen produce inflammatory changes. Clinical features. Onset types. Pauciarticular for a few joints involved, polyarticular 5 or more joints, and systemic with fever and rash. Pauciarticular juvenile rheumatoid arthritis may be of 2 types. Type 1, more common in female. Age of onset is about 5 years. Knees, ankles, and elbows are commonly affected. Small joints escape, low-grade fever, and easy fatigability. Iridocyclitis by slit lamp examination, secondary glaucoma, and cataract may occur. Antinuclear antibodies are frequently positive. Rheumatoid factor is negative. Second type occurs more often in boys. Light joints of lower extremities, usually the hip girdle, are involved. Sacroiliitis may develop. Self-limiting iritis may occur. Family history of ankylosing spondylitis, psoriasis, rheumatoid disease, and low back pain may be positive. Polyarticular juvenile rheumatoid arthritis, more common in girls. 5 or more small or large joints are affected within the first 6 months of onset. Loss of lumbar lordosis, diminished mobility of spine, low back pain is complained of. Polyarticular juvenile rheumatoid arthritis may be of 2 subtypes. The first subtype with rheumatoid factor positive. Age at onset is late childhood or early adolescent years. Arthritis is more severe. Rheumatoid nodules, low-grade fever, anemia are present. And next subtype with rheumatoid factor negative. This type may occur at any age in childhood. Flexion deformities of knees, wrists, and hips may develop. Proximal interphalangeal joints are involved. Hip movements are affected due to lack of mobility. Systemic juvenile rheumatoid arthritis, slightly more common in boys. Illness begins as intermittent fever rising up to 39-40 and may precede joint involvement by several weeks, even up to 6 months. There is a characteristic evanescent maculopapular rash with central clearing. Rash may be seen anywhere on the body. Pericarditis and interstitial lung disease may be present. Antinuclear antibodies can be deformed, but rheumatoid factor is negative. Laboratory investigation. Synovial fluid aspiration is done for microscopy and culture if septic arthritis is suspected. Full blood count should be ordered and bone marrow aspiration carried out if neoplasia is being considered. Goals of treatment of juvenile rheumatoid arthritis: suppression of inflammation, pain management, preservation of muscle strength, prevention of joint destruction, muscle atrophy, asymmetric growth, and other long-term sequelae. Treatment. Specific diagnosis should be made early to prevent residual deformities of joint or ocular handicaps. Physical therapy is done to relieve pain, maintain and improve joint mobility, increase the muscle strength, rehabilitate the child and plan. Psychosocial preparation of the family is necessary for better compliance in the management. Emotional support is given to prepare the family for prolonged treatment and to face possible frustration. Medical therapy. Non-steroidal anti-inflammatory drugs are the mainstay of management. For example, indomethacin in the dosage from 1 to 3 mg per kilogram per day, diclofenac sodium from 1 to 3 mg per kilogram per day. Disease-modifying antirheumatic drugs, hydroxychloroquine, dipenicillinamine, and gall salts, tauridone, auranafin, auritol, miacrezin. Corticosteroids are used for severe, unremitting arthritis and systemic manifestation. Cytotoxic agents like cyclophosphamide and azathioprine are very rarely required, but may be considered in children with severe erosive arthritis, not responding to methotrexate. Biologicals: TNF-alpha blockers, anti-interleukin-1 drugs, anti-interleukin-6 drugs. Fowl's disease is not controlled with non-steroidal anti-inflammatory drugs, steroids, and disease-modifying antirheumatic drugs, or who are intolerant of it. Significantly alter natural history and stop progressive of disease in a substantial portion of patients. Adverse events: infection, neutropenia, and increase aminotransferase levels. Complications of juvenile rheumatoid arthritis. More dangerous: macrophage activation syndrome, chronic arteriosuveitis, growth disturbance, atrophy, contracture and misalignment, cardiac disease, osteoporosis. And other complications include intercurrent infection, anemia, secondary amyloidosis. Systemic lupus erythematosus is a systemic connective tissue disease that develops on the basis of genetically determined imperfection of immunoregulatory processes, which leads to the formation of many antibodies to one's own cells and their components and the occurrence of immune complex inflammation with damage to many organs and systems. Diagnosis criteria of systemic lupus erythematosus: erythema butterfly, discount lupus, photosensitization, mouse ulcers, arthritis, serositis, pleurisy, pericarditis, kidney damage, proteinuria, cylindruria, damage to the nervous system, sodomy, psychosis, hematological changes, anemia, leukopenia, thrombocytopenia, lymphopenia, immunological changes, anti-DNA, anti-SM, antiphospholipid antibodies, and antinuclear antibodies. Systemic lupus erythematosus diagnosed when 4 or more of 11 criteria are present. Systemic scleroderma is a systemic connective tissue disease which is characterized by progressive fibrosis and vascular damage by the type of obliterating microangiopathy, which leads to the development of generation Raynaud's syndrome, induration skin changes, lesions of the musculoskeletal system and internal organs, lungs, heart, kidneys, digestive tract. Great criterion: proximal scleroderma, symmetrical thickening, stretched and induration of the skin of the fingers, possible lesions of the limbs, face, neck, torso. Minor criteria: sclerodactyly, osteolysis of the fingers types as a result of ischemia, fibrosis of the basal line. In the presence of one major or two minor criteria, the diagnosis is established. Dermatomyositis, polymyositis. Polymyositis is a systemic inflammatory disease with an overwhelming lesions of skeletal muscle, smooth muscle, and skin. Diagnostic criteria: weakness in the pains of the arms, legs, torso, increased CPK or aldolase, spontaneous pain, ulcers, changes on the electromyogram, positive RNA antibody test, non-destructive arthritis and arthralgia, signs of systemic inflammation, biopsy data. If there are more than 4 criteria, we establish the diagnosis. Polyarteritis nodosa. Nodosa polyarteritis, necrotizing inflammation of medium and small arteries without glomerulonephritis or vasculitis of arterioles, capillaries, and venules. Diagnosis criteria: weight loss of 4 kg or more, pain or tenderness in the testicles, diffuse myalgia, sensitivity of the muscles of the legs, mono or polyneuropathies. Diagnostic pressure is more than 90. Elevated area of creatinine levels, hepatitis B virus, arteriographic changes, biopsy changes. If 3 or more criteria are present, a diagnosis of polyarteritis nodosa can be made. Acute rheumatic fever. Rheumatic fever is an acute illness characterized by lesions in connective tissues of the joints, heart, blood vessels, less frequently affecting the central nervous system, skin, and subcutaneous tissues. Rheumatic fever appears to be an immunological disorder initiated by group A beta hemolytic streptococcus. It is social disease rampant in economically depressed societies, the most common cause of heart disease in children in the world. Predisposing factors. There are streptococcal throat infections. Early years, commonest age group involved is 5 to 15 years. Sexes are nearly equally affected. Mitral valve disease and Henrietta are more common in female. Aortic valve involvement is often in males. Poor socio-economic conditions, unhygienic living conditions, and overcrowded households. Pathogenesis. Rheumatic fever is an autoimmune disease. Antibodies produced against the streptococcal antigens, which cross-react with host connective tissue antigens and produce tissue injury. Thus, different sites, such as the joints, heart valves, which share antigenic characteristics with the streptococcus antigens, may be involved. During the acute stage, there is an exudative inflammatory reaction in the connective tissue of the joints, heart and skin, blood vessels, brain. There is edema and lymphocytic infiltration. All layers of the heart, the pericardium, myocardium, and endocardium are affected. In the joints, there is edema and articular and periarticular infiltration of the synovial membrane and effusion. Histologically, a Schaef's body, which is pathognomonic of rheumatic disease, is formed from 2 to 3 weeks after the acute phase. It is characterized by multinucleated cells arranged in the perivascular areas around and a vascular fibrinoid material. Classification. Activity may be of the first, second, and third degrees and non-activity. According to clinical anatomical characteristic, rheumacarditis primary, rheumacarditis recurrent, rheumatism without the cardiac change, myocardial sclerosis, and rheumatic heart disease. Extracardiac lesions, polyarthritis, sinusitis, pleurisy, peritonitis, abdominal syndrome, chorea, encephalitis, meningoencephalitis, cerebral vasculitis, neuromental disorders, vasculitis, nephritis, hepatitis, pneumonia, skin disorders, iritis, rhinitis, and thyroiditis. During acute, subacute, lengthy, continuous, progressive, recurrently, and latent. According circulation, heart failure absent, heart failure first degree, heart failure second degree, and heart failure third degree. Criteria activity of the third degree. Leukocyte less 8, erythrocyte rate sedimentation less 20, C protein 0 or 1 plus, sialic acid 0.18, 0.20, thermocoid less 0.3, titer antistreptolizin O normal or less 330. Criteria activity of the second degree. Leukocyte from 8 to 10, erythrocyte rate sedimentation from 20 to 30, C protein 1 plus or 2 pluses, sialic acid 0.20, 0.25, thermocoid 0.3, 0.6 unit, and titer antistreptolizin O 330 before 660 unit. Criteria activity of the third degree. Leukocyte more 10, erythrocyte rate sedimentation more 30, C protein 3 pluses or 4 pluses, sialic acid more 0.25, thermocoid more 0.6 unit, titer antistreptolizin O more 660 unit. Clinical manifestation. Rheumatic fever is said to lick the joints and beat the heart. The symptoms and signs are acute in onset and are recurrent or cyclic, occurring at intervals of 4 to 12 weeks. They depend upon the systemic involved. The onset is preceded by a history of sore throat. Rheumatic fever is a multi-system disorder. Symptoms characteristically occur from 2 to 3 weeks after the initial attack of sore throat. Arthritis. Joint involvement is typical. It may range from arthralgia to severe fleeting arthritis with swelling and pain. Usually the large joints, knee, ankle, hip, elbow, and wrist are affected. Sometimes the small joints may be involved. There is marked tenderness, redness, and swelling of the involved joints, no residual damage to the joint. The movements at the joints are restricted because of pain. The involvement migrates from one joint to another and is hence known as fleeting or migratory arthritis. Carditis. The cardiac manifestation can start as endocarditis without any other prior or associated symptoms like fever or arthritis. It is the most serious involvement as it leads to complications and may terminate fatally. present as a murmur, cardiac failure, pericarditis, may be asymptomatic. Tachycardia along with apical, high-pitched holosystolic murmur, grade 2nd, mitral valvulitis being the most common involvement. The other findings are an enlarged heart and sometimes signals of pericardial effusion with rapid and decrescent diastolic murmur due to the involvement of the aortic valve. Active carditis may subside within 6 weeks to 6 months. The residual effects due to valvular involvement. Chorea by author Sydenham's chorea affects adolescent girls in the group of 7 before 15 years. It is characterized by emotional disturbances with typical purposeless involuntary choreic movements, jerky movements resulting in deranged speech, muscular incoordination, awkward gait and weakness. The child becomes fidgety, nervous, clumsy, and drops objects held in the hand. Chorea is usually not accompanied by other involvements like arthritis or carditis. The cause is self-limiting, lasting for 3 weeks to 3 months. Subcutaneous nodules. They are better seen than felt. They occur over the scalp in the occipitation region and extensor surface of the forearm, elbow, and skin. The nodules are freely mobile, not tender, and vary in size from 1 to 3 cm. Erythema marginatum occurs in the severe cases and consists of erythematous patches with a well-defined border. The rash is faintly reddish, not raised above the skin and not itching. They are seen on the trunk and extremities, but may not be readily visible in children with a dark complexion. Diagnosis according to Jones criteria. Major manifestation. There are carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor manifestation. Arthralgia, fever, elevated acute phase reactance, erythrocyte sedimentation rate, and C-reactive protein. Prolonged PR interval. Supporting evidence. Positive throat culture for group A streptococcus or positive rapid streptococcal test. Elevated or rising streptococcal antibody titer. One major and 2 minor criteria are required in the presence of essential criteria to diagnose acute rheumatic fever. Laboratory investigation. Throat swab culture for streptococcal growth may be useful. Antistreptolizin O titer is usually elevated above 250 tot units. Streptozim test and test for antinuclear antibodies, especially against DNA and DNP, are supportive of the diagnosis. Erythrocyte sedimentation rate and C-reactive proteins are elevated during the acute and active phase. They are useful to assess the activity of the disease. Routine blood examination shows moderate anemia and leukocytosis. Electrocardiogram is useful in cases with cardiac involvement. Prolongation of the PR interval in the absence of other clinical findings suggests cardiac involvement. In case of myocarditis, flat or inverted T waves and elevation of CT segment in the pericarditis is found. X-ray chest may show cardiac enlargement. Treatment. In the first place, bed rest. All the patients with acute rheumatic fever should be kept on bed rest, and in those with carditis, the bed rest should be prolonged till all evidences of activity subside. Diet number 10. In the absence of cardiac involvement, there should be no restriction in salt intake. Medicine. Benzene penicillin 1,500,000 before 4 million for all the children, and from 600,000 before 1 million for children of early age for 10-14 days. Then benzathine penicillin, Obicillin 5. The dosage 600,000 before 800,000 for children, and from 1,500,000 before 2,400,000 for all the children, one time in 2 weeks. Non-steroids anti-inflammatory medicine, such as aspirin, 0.2 per kilogram from 10 to 40 days, indomethacin, the dosage from 2.5 before 3 mg per kilogram, Voltaren from 3 to 3.5 mg per kilogram, Brufen 400 before 800 mg in 24 hours. Steroids. Prednisolone in the dosage from 1 to 2 mg per kilogram, and other drugs for symptomatic treatment, such as acetaminophen, ascortinum, antihistamine drugs, panangin, asparagam, riboxin, cardioglucosides. Management of chorea. Physical and mental rest. Voltaren, indomethacin, phenobarbital 2-3 times during 2 weeks, then only tonight, Siduxin, aminazine, B groups vitamins, for example B1 and B6, from 15 to 20 injections. Physiotherapeutic procedures. Prevention of rheumatic fever. Primary prevention requires identification of streptococcal sore throat, its treatment with penicillin, stimulation of the reactivity. Secondary prevention consists in giving long-acting benzathine penicillin, 1,200,000 units once every 2 weeks, less 10 years, 600,000 units. Macrolides may be used in the patient is allergic. 250 mg 12 hourly, 10 days every month. Rheumatic heart disease include mitral regurgitation, mitral stenosis, aortic regurgitation, aortic stenosis, and tricuspid regurgitation. Mitral regurgitation is the commonest manifestation of acute as well as previous rheumatic carditis. Mitral regurgitation results in a systolic leak of blood to left atrium. The regurgitant volume of blood reaches the left atrium during ventricular system at almost systemic pressure. During diastole, it can pass freely across the mitral valve. Clinical picture. Pulse pressure is relatively wide. Heart size is dependent on the severity of mitral regurgitation. Cardiac apex is displaced downward and outward with forcible apex. First sound may be soft, normal, or accentuated. Second sound is widely split. Third sound is audible at the apex and indicates increased early rapid filling of the left ventricle. Pansystolic murmur, best heard at the apex and widely radiating to the axilla and back as well as to the left sternal border. In electrocardiogram, Siemens tachycardia and normal axis ventricle hypertrophy. X-ray investigation show cardiac enlargement. Echocardiogram, enlarged left atrium and ventricle. In the Doppler echo, can quantitative mitral regurgitation non-invasively. The medical management consists in the use of dechetals, diuretics, and vasodilatators besides prophylactic antibiotics for prevention of recurrences of rheumatic fever. In the presence of severe mitral regurgitation, operation is indicated. Rheumatic mitral stenosis. Mitral stenosis results in obstruction to flow of blood across the mitral valve during the left ventricle diastole. Left atrium compensates by increasing its pressure, hypertrophy of the left atrial wall. Increased left atrial pressure is transmitted to pulmonary veins. Shortness of breath on exertion or rest depending on the severity. Consists of Koch hemoptysis, paroxysmal nocturnal dyspnea, attacks of acute pulmonary edema, and atypical angina. The pulse appears to be small volume. Respiratory rate is increased. May or may not be signs of right-sided congestion, enlarged neck veins, and enlarged tender liver. Examination of the precordium reveals a normal-sized heart with a tapping apex beat, parasternal impulse, and an apical diastolic trill. The first sound is accentuated. The second sound normally split with a loud pulmonary component. An opening snap of the mitral valve is best audible just internal to the apex. The delayed diastolic mitral murmur starts immediately following the opening snap. The late diastolic accentuation is always present. In electrocardiography, a right axis deviation with right ventricle hypertrophy, P-mitraille. In X-ray investigation, normal-sized heart with features of pulmonary venous and arterial hypertension, as well as left atrial enlargement. Echo shows decreased EF slope, paradoxical posterior leaflet motions, left atrial enlargement, and pulmonary arterial hypertension. 2D echo can identify the narrowed mitral opening, Doppler echo provides transmittal gradient accurately, non-invasively. Treatment. The management of mitral stenosis is essentially surgical. The patient should be digitalized and given diuretics. Digitalize help by reducing the heart rate and increasing the left ventricle filling, increasing the left atrial contractility, maintaining a slow heart rate on exertion and thus a better forward flow. Aortic regurgitation. Aortic valve involvement in the rheumatic heart disease results in aortic regurgitation. Rheumatic aortic stenosis has never been described in the pediatric age group. Clinically poor aortic regurgitation without associated mitral valve disease is rare and occurs in 5 to 8% patients. Aortic regurgitation is a backward leak from the aorta into the left ventricle during diastole. The left ventricle increases in size to accommodate the extra volume. This is compensated by peripheral vasodilatation. The dilatation of the left ventricle is accompanied with abnormal stress on the mitral valve, papillary muscle complex. Clinical picture. The pulse pressure is wide. The diastolic blood pressure may be recorded as zero with aortic regurgitation. Prominent carotid pulsations, correction signal. Visible arterial pulsations over the extremity vessels, dancing peripheral arteries. Visible pulsation of the abdominal aorta, nodding of head with each systole, Muset signal. Holding the middle of the forearm or leg and elevating it discloses a sharply rising and abruptly failing pulse, Corrigan pulse or Waterhammer pulse. Arteriolar pulsations may be seen over the nail bed, jugular, lips, ear lobes, and in eye grounds. Exaggeration of the systolic pressure difference between the